Roles and responsibilities of a fertility nurse. How to be a fertility nurse. 1. What is fertility nursing? Fertility nursing is a complex yet exciting field for those who wish to help patients with fertility issues. This is also called reproductive nursing. Science is rapidly able to control reproductive life, so the demand for fertility nursing will only grow in the future. A fertility nurse is responsible for managing the entire fertility treatment of a patient. Fertility treatment is specialized care and it involves a lot of time, so it is important for a nurse to guide patients through all the steps and treatment with a lot of careful handling and sensitivity. A fertility nurse is an important link between the doctor and the patient. Fertility nurses are at the forefront of patient care. A. What does a fertility nurse do? Here are some roles of a fertility nurse. Help a patient to understand the treatment and procedures involved. Offer emotional support to patient. Schedule and coordinate procedures, tests and follow-ups. Monitor fertility cycles. Draw blood for tests. Help with ultrasound procedures. Help and assist in giving IVF treatments. Support with counseling sessions of both the patient and donor. B. What are the job characteristics of a fertility nurse? The job of a fertility nurse is multifaceted, structured, patient-oriented and research-friendly. Apart from this, fertility nurses assist with laboratory reports, advise patients with dosage and medications or hormones and timings, count follicles, measure uterine lining, administer hormones that prevent miscarriage and promote ovulation, and control timings for IVF, IUI, and egg retrievals. 2. Sonography, ultrasound. Integral and essential part of fertility nursing practice. Sonography or ultrasound is now considered to be an integral part of fertility treatment. It requires specialized training and assessment. Many specialist nurses are now required to perform ultrasound techniques of tubal patency testing such as 1. Hysterosalpingo contrast sonography and 2. Hysterosalpingogram. Both these examinations could also be a part of routine clinical fertility nursing practice. Both diagnostic tests are highly dependent on the observer, so accuracy is needed and a trained nurse is definitely an important requirement. Once a nurse is certified in sonography or ultrasound, the following skills are developed. To understand the indications for ultrasound examinations. To perform scans safely and accurately. The nurse can then assist in fertility ultrasound through ultrasound examinations in the management of fertility, ultrasound assessment of the normal female pelvis, recognize uterine and ovarian pathology, ultrasound assessment and diagnosis during follicle tracking, ultrasound assessment and role in the management of assisted conception, ultrasound diagnosis of normal early pregnancy, ultrasound diagnosis of early embryonic demise, and ultrasound diagnosis of a suspected ectopic pregnancy. A fertility nurse should be well trained in the following procedures in ultrasound imaging: ultrasound equipment controls, emission and reception, reflection and refraction, attenuation, artifacts in ultrasound imaging, recording of ultrasound images, and hygiene control, delivering reports, ensuring safety methods. 3. Pre-treatment evaluation in ovarian infertility. Pre-treatment evaluation in ovarian infertility means to evaluate a diagnosis in the patient after which the right treatment is started. In ovarian dysfunction, the endocrine status has to be evaluated. Here, patients can have 1. Estrogen positive or 2. Estrogen negative. In the estrogen negative category, further subgrouping has to be done according to the FSH and LH concentration. For both estrogen positive and estrogen negative patients, the prolactin and androgen status as well as thyroid function has to be tested. Once information on estrogen, gonadotropin, prolactin, androgen and the thyroid status of the patient is received, then the selection of the type of stimulation therapy can be done. 4. Best practices in IVF nursing. Let us take a look in some best practices in IVF nursing. There are 3 main areas which an IVF team should address. A. Whole patient care. When a patient has been diagnosed with infertility, we should be concerned with both the patient's physical and emotional well-being. Many times, due to a lot of stress, a patient stops the treatment halfway. A support group where couples share their concerns and feelings in a warm, nurturing environment could be encouraged. If a fertility nurse learns relaxation techniques, this can help patients deal with stress, which will help in the regaining some sense of control and decrease stress on fertility. B. Coordination and communication. Staying connected with the patient is very important. Lines of communication via phone and internet with our patients at the time of the initial visit should be established. On subsequent visits, the IVF nurse uses face-to-face communication. Mostly, phlebotomists perform blood tests, but if the IVF nurse does this activity, the patient feels very reassured. This is an excellent opportunity to interact with the patient, provide support and answer questions. These daily meetings with the nurse decrease patients' stress levels and help to minimize errors in medication. C. Empowerment and patient support. The IVF nurse should provide patient support as and when needed and encourage patients. A good IVF nurse should be able to improve patient care by evaluating all processes carefully and by carrying out necessary changes in the treatment. Meetings should be held regularly where information interchange happens. New processes and guidelines could be exchanged at these meetings. 5. Oocyte recovery. Transvaginal oocyte retrieval (TVOR) is also referred to as oocyte recovery. This is a technique used in vitro fertilization (IVF) to remove oocytes or eggs from the ovary of the female, enabling fertilization outside the body. Transvaginal oocyte retrieval is more properly referred to as transvaginal ovum retrieval when the oocytes have matured into ova, as is normally the case in IVF. The procedure TVOR is typically performed after ovarian hyperstimulation where oocytes are stimulated to mature. This is done pharmacologically. When the ovarian follicles have reached a certain degree of development, induction of final oocyte maturation is performed, generally by an intramuscular or subcutaneous injection of human chorionic gonadotropin. TVOR is typically performed 34 to 36 hours after HCG injection when the eggs are fully mature but just prior to rupture of the follicles. TVOR is performed with a transvaginal ultrasound transducer with an attached needle in an operating room with the patient in the lithotomy position. Generally, it is performed under sedation, general anesthesia, paracervical block or sometimes spinal anesthesia. Local anesthesia is not typically used because local anesthetic agents interfere with follicular cleavage and the technique requires multiple needle punches. A. With the help of ultrasound, the IVF nurse inserts a needle through the vaginal wall and into an ovarian follicle, taking care not to injure organs located between the vaginal wall and the ovary. B. The other end of the needle is attached to a suction device. C. Once the follicle is entered, suction is gently applied to aspirate follicular fluid and with its cellular material including the oocyte. The follicular fluid is then assessed in the laboratory to identify and quantify the ova. In the next step, other follicles are aspirated. Once the ovarian follicles have been aspirated on one ovary, the needle is withdrawn. The procedure is then repeated on the other ovary. Usually, it will be found that as many as 20 oocytes will be removed, as women are generally hyperstimulated in advance of this procedure. After completion, the needle is withdrawn and hemostasis is achieved. The procedure usually lasts 20 to 60 minutes. Sperm is added to the eggs and the next day, eggs are checked for evidence of fertilization. A suitable number of embryos are transferred to the uterus some days later. What are the complications? Injection of HCG as a trigger for ovulation carries a risk of ovarian hyperstimulation syndrome, especially in women with polycystic ovary syndrome who have been hyperstimulated during previous assisted reproduction cycles. Other complications are injury to pelvic organs, hemorrhage, and infection. Occurring more often in lean patients with polycystic ovary syndrome, ovarian hemorrhage too can occur. Additional complications may result from the administration of intravenous sedation or general anesthesia. 6. Embryo transfer. The embryo transfer procedure is the last and most critical part of the in vitro fertilization process. No matter how good the IVF procedure has been till now, everything can be lost if the embryo transfer is done carelessly. The importance of proper embryo transfer technique for successful IVF is very high. Procedure. The entire IVF cycle depends on delicate placement of the embryos at the proper location near the middle of the endometrial cavity. With minimal trauma, ultrasound-guided embryo transfer is the most effective technique currently available.